So we're going to talk about deprescribing, which interestingly has become somewhat of a hot topic over the past few years. I was just at the IAGG conference in San Francisco, and there were several sessions on this topic. And it's also interesting to note that most of the research that's being done on this is coming from Australia and Canada. So there's still a lot of room for opportunity in the US to move this forward. So what is deprescribing? Essentially, we're thinking about medications that may have once been good, but might not be the best choice now. And you can think about it as part of good prescribing. And it includes two things, both backing off on doses if they're too high, as well as stopping medications that are no longer needed. So it's not just discontinuation. It can also include reducing doses. So when you think about prescribing, there's an indication, you assess the benefit and risk, and then you prescribe. Deprescribing is simply the opposite of that. You're similarly looking for an indication to stop a medication in the event that there's low benefit and or high risk. So this is a really nice article. I would recommend pulling it if you're interested in learning more about this topic by Scott et al. From a couple of years ago. And I think this definition is very geriatric-centric. They talk about a systematic process of identifying and discontinuing drugs in instances where the existing or potential harms outweigh existing or potential benefits in line with the patient's goals, function, life expectancy, values, and preferences. And so really that part about potential harms and potential benefits means that we have to think ahead a little bit. And even if the patient currently is not having any problems, might there be problems in the future if there are any changes in their goals of care or function? So like I mentioned, deprescribing is part of the good prescribing continuum. It is not about denying effective treatment. So there's really a lot of communication that needs to take place so patients don't feel like we're withdrawing care. It's a positive patient-centered intervention. There are inherent uncertainties, and it really requires shared decision-making, patients, buy-in, and close monitoring. And when I say that, you probably think, okay, so this takes a lot of time, and that, in fact, is very true. So when would we think about stopping a drug? These are just a few examples of when we might think to stop a drug. Diminished benefit. If there was an inappropriate drug initially, that's a pretty easy thing to fix. If there's not an indication, if there's a new condition, if the patient or you want to see if the medication is still needed, of course during the perioperative period, and then late in life. We're starting to see some studies come out, particularly about stopping statins in patients with limited life expectancy. Not surprisingly, compared to drug initiation trials, the evidence for deprescribing is quite limited. But what we do know is that it seems to be feasible, safe, and in many instances beneficial. And you're probably not surprised to hear that the interventions are typically multifaceted. It involves a lot of the healthcare members on the team. I'm not going to go into detail about this, but I just want to show you one, I think, shining example of how this might work. This was a publication from Kara Tannenbaum in Canada, where they worked through community pharmacies to send patients direct education about stopping or discontinuing their benzodiazepines. And they showed a significant impact of this direct-to-patient education, such that in the intervention at 6 months, 27% had discontinued benzos compared to 5% in the control group, with a number needed to treat of 4, which is a pretty impactful intervention. So this is one example of the fact that these sorts of interventions can work. So this article from Scott et al. Kind of goes through a step-by-step process of how to do this. The first step, as we always do, is a complete medication reconciliation. You want to consider the overall risk in determining how you're going to proceed. And then you're going to look for indications for each medication if there's a reason to stop the drug. And we've talked about some of these before. And then you need to prioritize because you can't do it all at the same time. So some top priorities could be drugs that have the greatest harm or the least benefit, those that are easiest to stop, meaning those that are least likely to have withdrawal reactions or have recurrence of the underlying disease, and also the drugs that patients are willing to stop, because a lot of this comes down to what the patient is willing to do. And so if there's one that they're particularly interested in stopping, that could be a good place to start. If you're a visual learner, this is basically what I just said in words in the form of a figure. This is also from that Scott article. A key point here is that you want to think about drugs for which there are withdrawal symptoms, because that's a completely different approach to deprescribing. And I'll talk about some of those drugs and drug classes in a couple slides. And then I think a really important part of deprescribing, in addition to the communication with the patient and the other healthcare providers, is the monitoring. So you want to cease one drug at a time, and really importantly, document the reasons for and outcomes of deprescribing so that the next person who comes along knows exactly what was tried, what the results were, and they can make an informed decision about how to proceed. So as soon as I said deprescribing, you probably thought, oh my goodness, this is very complicated. He's simplifying it. And of course, that is true. This is very complex stuff. There are many barriers, a few of which I've listed up here. So our older adults are highly clinically complex. Time is of the essence. This takes a lot of time. We're still working in a healthcare system that has very fragmented care, oftentimes with incomplete information. Goals of care can change. A lot of times we just don't have the evidence that we need to know what the benefits and harms of continuing or stopping a drug. So we're working basically in the space of the art of medicine, which can be a little bit unsettling at times. We also operate in a medical culture where more is thought to be better, although this is changing as we shift toward more emphasis on value. And then clinical practice guidelines really drive a lot of what we do. And if you follow all of them, sometimes patients will end up on many, many drugs, some of which are interacting. And so clinical practice guidelines, hopefully over time, will begin to include sections that talk about when it might be appropriate to stop medications. So this is a table from an article back in 2008 in JAGS that lists medications and medication classes that might be associated with withdrawal events. And you can think about the way these might manifest in two ways. The first being a physiologic withdrawal. So a classic example would be benzodiazepines. Or alternatively, the underlying disease could recur. So if somebody has heart failure, for example, and you take away a medication that's treating their heart failure, that underlying condition can flare up. So think about those two ways that a withdrawal event could occur. I'd just like to highlight on this slide, antidepressants are pretty common in terms of having withdrawal. Of course, anti-Parkinson's agents, you typically never want to withdraw those. And on the next slide, we see some others that are very common, benzodiazepines, narcotics, which we'll talk about today in the case. And some of these we could debate, but this is essentially the point being that you want to stop and think, does this drug have a physiologic withdrawal associated with its cessation, or is this a condition that could flare up? I borrowed this slide from Kate, so thank you, Kate. And this is really just hitting home the point of starting with the low-hanging fruit. So when you see a medication regimen that has duplicates, that's an easy intervention. Ineffective medications or medications not taken, so non-adherence, or medications without an indication. These are kind of the low-hanging fruit that you can start with. So I wanted to finish by pointing out a couple resources on deprescribing. The first one is this website called Medstopper. This is developed by folks at the University of British Columbia. And you can see from the webpage here that it's still in beta testing. But essentially what they're working toward is the platform where you could enter all of the patient's medications, and you can even click if the patient is frail or not. And it'll give you a prioritized list of medications that you could consider stopping, as well as some additional information on how you might do that. So they still have a lot of work to do on this, but this could be a nice tool in the future to just begin to help you think about where you might start. And then this website is really, I think, kind of the gold standard in the field right now. And if you take nothing else away from my talk today, please just go to this website. It's deeperscribing.org, and it was developed by a geriatrician and a pharmacist in Canada, again, Kara Tannenbaum. And they've been working on it for a few years now, and it's really showing some great progress. So they have currently 4 deprescribing algorithms for these medication classes listed. And I took a screenshot of one, the PPIs, just to show you what it looks like. It's a 2-sided document. Basically, you just work down like a typical algorithm. And on the back side, it has more information listing the specific medications, standard dose, low dose. And then also on the right column, you see some additional content about side effects and tapering doses and what the current evidence suggests. Now, in addition to this, patients are very important in this process. And so you might think, well, I'd like to give my patient some information on this. And so they thought of that and they developed information pamphlets for these medications listed. And I took a screenshot of the PPI one just to show you an example of what that might look like. So it's very patient-friendly language. And on the back, they list some non-pharmacologic ways to reduce heartburn and such. And there's a space for you to document what your dose reduction strategy might be. So again, visit the website, maybe make it one of your favorites so you can learn more about what they're doing. But there's a lot of good content coming out of this group's work. And then for our case today, I just wanted to end by talking about opioids. The CDC has some great content on tapering opioids. This one in particular is just a pocket guide. It's pretty simplified. I won't get into the details, but you can check that out. And I wanted to highlight the fact that Washington State, in particular, is really progressive. And along those lines, they put out this report. It's a guideline on prescribing opioids for pain. And it's meant to be used by clinicians who are caring for people with pain. This is the edition from 2015. And within that document, they talk about when it might be appropriate to reduce, taper, or stop chronic opioid therapy. So one example could be if the patient requests an opioid taper. Another one is if the patient's on it for at least 3 months, but there's not meaningful improvement in function, or if they have a severe adverse outcome. So there are many components to stopping opioids. I just thought I would focus on the pharmacologic aspect for now. So the first and most important thing is that you want to base your rate of taper on safety considerations. So if there is diversion or non-medical use, that can be a quick taper. If the patient has a bad outcome, that can be somewhat of a rapid taper over a few weeks. But if you're just talking about someone who you have time and there's not an acute safety concern, typically what's recommended is 10 or less % reduction per week in the original dose, with routine follow-up, seeing how the patient is doing in terms of function and pain. And then finally, this is another resource that I wanted to include from the Mayo Clinic that was written and published to be used by internal medicine physicians and other folks caring for people with chronic pain. And so there's a lot of good resources in here beyond just how do you specifically taper a drug, screening tools and monitoring tools, et cetera. So I'll end with this quote from a French physician from many years ago. And he says, "It's an art of no little importance to administer medicines properly, but it's an art of much greater and more difficult acquisition to know when to suspend or altogether omit them." So emphasizing that this is very difficult, but it's important work, and I think we're making progress. So thank you.